So I can see we're kind of building on this theme as we go through, and I can see there are some really interesting questions coming through on the Slido already. I would now like to welcome another Cisco Research Chair to the podium. We've had Trish, Cisco Research Chair, and now we're going to have Associate Professor Alison Craswell, who is Cisco Research Chair in Digital Health and Ageing. I don't know about you, but I've been hearing lots of in my mind's been ticking over on the ageing question as we go through the proceedings today. Alison's research seeks to better understand care needs for older adults to age well, harnessing digital solutions. In collaboration with local health services, and specifically Caboolture and Sunshine Coast hospitals, not a bad part of the world, this research is challenging clinicians to innovate and think differently. Industry partners are supporting development of co-designed solutions with older adults. Near and dear to my heart, Alison, the floor is yours. Please welcome her.
This one? Yeah, I think I'm going to try. So this one's off. I'm not going to start squeaking. I like a podium. Sorry. And probably should click.
You can use the lapel if you prefer.
Click. Oh. So I've changed our slide background to our university background. I'm from the land of the Gubbi Gubbi people, and this artwork is done by Lyndon Davis, who is a honorary doctorate holder at our university and local Gubbi Gubbi man on the Sunshine Coast. So rather than digital health and aged care, my background and work in research is digital health and ageing. I'm first a clinician, nurse midwife by background, and researcher second. I am part of the NIN on the NIN Health Advisory, and my research focus while being on older adults looks at workflow, health services and those digital solutions for older adults, which in the Sunshine Coast we are a sea change destination. We have a very high older adult population, so often called a living lab for that reason. And you'll notice there that it's care for and with older adults, which we are trying to change that narrative that we are doing to people rather than doing with people. However, our sector is really complex and really fits nicely into that whole idea of wicked problems. We have private and public providers, which, depending on which state you are in Australia, can be very large in the public sense, lucky Victoria. In Queensland, very, very small in the public sense. We have a high private and not-for-profit providers in home care and residential aged care. And you've also got to remember that home care is community, people living at home, but also people living in retirement living communities. They are not aged care communities, and yet people move into retirement living communities thinking of this as their last move. No one is choosing to go into residential aged care if they can help it, but providing support for those people is really important as well. The acute care still is a touch point, because when you have an acute issue, just because you're older doesn't mean that you don't need care for that. So being cared for appropriately in the acute sector is really important. So massive complexity. We've of course got an increasing proportion of older adults in the population. They're saying in the next 10 years we get another 2 million people over 70 years old. And because we're living longer, there's not 2 million older adults dying during that time to keep those numbers steady. And we're in the 7th year of flux governance change as a result of the Royal Commission. That final report, well, commenced in 2019 and final report in early 2021, I believe. and dealing with all of that change is really tricky across the sector. Then you add in rurality and the disadvantage that comes with that, and really it's just a mess. But it's not without hope, and we see solutions already existing in the marketplace that really just need to be adapted and adopted well to this environment to be able to see change and take on the benefits of that solution. So we know that healthcare overall is quite slow, has been a slow sector to transition to technology and digital adoption. Well, aged care has been even slower. However, when there's funding to be gained, and going back to both Vince and Brendan's comments about the dollars being the drivers, their back-of-house systems are all really efficient at being able to use AI even to work out where in their billing they might be missing out on funding. So in the sector we have quite well-developed back-of-house technology systems, but where my interest sits is with frontline healthcare provision and how we can use digital solutions to improve what the customer experience is in the older adults themselves and the frontline clinician who might be providing that service. It's really lagging in frontline care, and that might be because of things already spoken about today. Fear of AI, fear of anonymity being taken over by monitoring, by sensors, by sharing of health data. And for the clinical staff providing those care, it's often their prior experiences which have been negative. A poorly implemented technology solution is a dangerous place to start, because when you go in with something that you want to help people change and make an improvement to their care, they only focus on that prior negative experience. So they're also very concerned about improving the outcome for their patients rather than what the people at the back of house might be more concerned about, which is the bottom line. So we see masses of digital opportunity in the care of older adults. The innovations in action that some of you might actually know about are things like in falls prevention, in functional decline, in improving workflow. Falls prevention, we use AI to monitor changes in people's gait. We use cameras for anonymity. That might be cameras at a really low level, so it's only when someone's on the floor that we can actually see them. Functional decline, there are mood rings in development that can detect grip strength changes, but we have issues with older adults in terms of wearables because with cognitive changes, people might not want that or understand enough about a wearable to know they're being monitored. In areas where we're caring for people with dementia, we can use wander guard systems to know when someone's approaching a door and lock that door so they can't get into an unsafe situation. However, if they can remove their wearable because they don't want to be tracked or they want to go and commit suicide at that particular time, then you know, those sorts of solutions don't work. So thinking outside the box in how to adapt that into this sector is really important. So, you know, innovations in development, things like delirium detection, where we can use cameras to see the particular physical behaviours we know appear when delirium starts in both acute hospital settings and in just the simple care of older adults. And we can use them in violence prevention, which is in emergency departments now. There are cameras in place which help to look for instances that happened. And I know Architect have a lot of this in their digital front door system as well. So in terms of cases of these, we want to look at solutions that are going to keep clinicians working where they're needed. So I'll give you two examples. One is that some of you might have heard of social robots. So a researcher developed a social robot that was called a Paro, and Paros can be used with older adults to interact with and feel, have connection with. But those robots need charging, they need cleaning, they need updating for their software systems, and that's all done by a human. So that time that human spends doing that could be spent with the older adults. Yet other digital solutions like ambient listening for recording of notes could be used to decrease the time the person needs to spend at the desk transcribing everything that they've done for the day so that can be passed on to the next person. So I think it's about thinking where the solutions are going to make the biggest bang for their buck, but keep the outcomes, the improvement for the older adults at centre. And of course, the key to all of this is integration with our clinical partners and our consumers to take clinical insights in to bring these solutions to life rather than go in with a solution and try and retrofit it. So one of the projects I'm working on with my team at the moment is in workplace violence detection. So we're looking at how we can use cameras to detect increasing agitation, moving to anger in people with cognitive impairment in acute care settings. Specifically, we went in with this approach to be a falls prevention program, but were told quickly by the hospital that actually workplace violence is our biggest problem in this group. We want to do something different here. Can you work in this area? So we have adapted to that. And we're in the process of trying multiple machine learning models, off-the-shelf models, and working with older adults doing videoing to see if we can come up with something that looks at levels of agitation developing. Most of the models that are in place look at moods or emotions. So you're either angry, you're either sad or happy, whereas we want to look at you're angry, but how angry, as in what is the developing state, so that we can give our healthcare professionals warning of when they need to start de-escalation procedures, when they can step back to decrease the risk of violence for healthcare staff, but also the impact of that on the older adult and their family, which can be quite negative. So we work with the health services, older adults, home care providers, RACFs in defining where the innovations will work, harnessing the implementation strategies that are effective, and using our health productivity lab to develop proof of concept. So the Flinders example of the multiple labs they have out at Torrens is sort of our next step where we're getting at University of the Sunshine Coast. So watch this space. So in terms of research in practice, our team aims to empower clinician researchers, help their development as much as our own projects, to show what is possible and share those successes. We also work closely with consumers, a number of older adults who help put our research into plain language. One of the projects we're doing at the moment is up on the screen, where we're just gauging frontline clinicians' understanding and experience of digital technology and where they see innovation as being successful. And already those results that are coming through are showing such a breadth of exposure to technology, from your home care untrained worker right through to clinician managers in the sector. And I think that's, the end for me. I just want to say the final aim is we're really aiming to improve care for older adults, safe, connected, appropriate care that focuses on choice. Thanks very much.
Thank you, Alison.